now the floor is open for questions. Brandon?
So my question's for Megan. Great presentation, really liked it. I was wondering about, as you've gone through a bunch of these head and neck patients that have lost weight during the treatment, you're seeing underdosage of the target structures. Might you have recommendations for how we should be doing our PTV for these structures? Typically, we just do a uniform expansion, but maybe based off of this data, we should consider expansions in certain directions.
Yeah, I definitely think that there can be contouring implications of adaptive radiotherapy. I'm hesitant to offer a recommendation based on the 12 patients that we've looked at, just because that's a really small cohort. These patients have also been handpicked, but as patients that we saw their cone beams demonstrate anatomical changes, as opposed to more of a randomized look at lots of different patients. So this, this data set is kind of like the worst case scenario. But we do see, at least in the target coverage, that the changes tend to be around the shoulder regions. So I think, when you're doing your contouring or you're doing your planning, being, creative about how you're avoiding those shoulders can definitely help mitigate some of those cold spots.
Yeah, and also Megan, kind of along that line, since now the tool is kind of limited for us to do online adaptive therapy. These kind of offline analysis, such as the ones you guys conducted, can you offer some recommendation based on your data in the clinic? What kind of sites and what kind of frequencies we can put in our limited resources into investigating adaptive that would get the most benefit?
Yeah, that's a great question. So I think on the head and neck side, what we've seen is that if we do a weekly analysis of the patient's anatomy and their delivered dose, I think that should be adequate to have a good idea of what's going on with their treated dose and then mitigate some of those effects. For prostate patients, the question is a little harder because those bladder changes are happening every day. So you might have a 50% overfill one day and then be only filled to 25% of the SIM volume the next day. And so for those patients, I think it's more important to have these interventions that kind of reduce the spread in bladder fill. And then you might be able to move to something like a weekly analysis for them to look at other effects that don't change as much day to day.
Mm-hmm. Yeah, that's definitely another nice feature of these studies, point out dosimetrically how much effect those anatomy variation from day to day could be on the plans. And so this next question is for both you and Wei. I found it very interesting that in your slides, there are some quite contradictory results comparing different vendors for their deformable registration results. And on the Phantom study that we showed, actually one vendor velocity outperformed the other vendors quite a bit in the arrow histogram. But from the patient, the slide that you show, it seemed to indicate that the hybrid method like RayStation is better deforming the OERs than the intensity-based i.e. velocity and MIM. So just want to get your comments on that. And also, as the clinical team, what kind of QAs we need to do to basically ensure that we can trust these deformable registration?
Yeah, so I'll take a stab at it and then Wei can add anything that he wants to after that. But I'd have to dig a little bit more to understand why the Phantom studies indicate, one performance and the patient studies indicate another. But if I had to make a guess, I would say that the RayStation algorithm does some biomechanical effects. So the algorithm knows that bone should not be morphing as much as a bladder. And so that's built into the algorithm. So with a patient, you've identified where the bone is and where the bladder is, and it can use that in the deformation. Whereas in a Phantom study, these are digital phantoms, they're not actually human bodies. And so those biomechanical effects are not going to be applied. And so that's where RayStation may underperform. That's just my guess, but I'd really have to dig a little bit more into the data, and Wei can weigh in on this as well.
Yes, I agree with Megan. So I noticed that the data I show you in the histogram is in the early days. So at that moment, I'm not sure what's the development of the software on that stage. Another thing is they evaluate in different criteria, like the Japanese group, they evaluate the Huntsville unit at different at the same spot. So in that case, the velocity looks much worse than RayStation. But when they plot the area of the displacement in transformation, then it looks like velocity is better, but I have to look in details how they calculate.
And then to answer the second part of the question, I think the first thing that's really important is to do some QA of the system before you release it for clinical use. And there is some guidance on this from the AAPM. And that's something that we've done with our system. So shout out to Shuo Wang for doing that work. And then when you've done a specific deformation, I think the first thing to do is to look at it visually. And I kind of showed that in the demonstration, looking at that displacement grid and the vectors, making sure that your contours are deforming where you expect them to. The next thing you can do is look at the Jacobian determinants, which Wei showed. And then lastly, you can do kind of point-based QA where you identify a point on each image and make sure that it's gone where you expect it to. So there's lots of different tools that each of these systems has in order to evaluate one specific deformation. But like I said, that QA process at the beginning where you validate the system for your clinical use is a really critical step.
Thank you guys very much. And Dr. Ink?
The first question's for Drew. So actually, I really like this project that you're working on. I guess a question that I had, one of the images that you first showed demonstrated a cone beam CT that because of the field of view, it cropped off some of the lateral structures. So during, I guess, in trying to automate this, is there any potential problem, or is the idea in something like this for spine, you're going to try to keep these angles, is it's going to be probably a 3D plan, you're going to keep things pretty close, you're not going to come in from laterals. Is that kind of the idea?
So the field size of a full field of view cone beam, I think, is 47 centimeters. So we will run into that pretty often. So basically my script will have 3 treatment planning options. So we'll have like a 3-field option, which should work for most of those cases that cut off the sides. We still get enough of the PA portion of the patient to do a 3-field. And then we'll have an APPA option. And then for those patients that do fit inside, a conformal arc option, which is something we've been using a lot. So yeah, that is an issue, but we should be able to deal with that pretty effectively with different, beam arrangements.
Yeah, I think if you provided those kind of scenarios, I agree that should cover most contingencies. My second question was for Megan, Dr. Hun. So you had kind of talked about one of the things in practice, I think based on some of the initial work you did, that the therapists on the machine kind of wanted a no-go contour to really kind of help in their decision process. Like, yes, we need to stop at this point, get the patient down. And, to your point, I think our patients, they do all get instructions on bladder filling, but I think where the problem does occur is in the simulation, they're used to saying, gee, I know it takes an hour from when I drink to when my bladder feels full. They do that, they come in, there's the sims behind whatever, there's a delay. And so by the time they're imaged, it's not 60 minutes, it's 90 minutes after, and they're bursting at the seam. Is there a no-go option that, from a workflow standpoint, that we really should put in the simulator? I assume the no-go that you're doing now is based on maximal versus at some point this is too low.
Yeah, that's a really great point. So the no-go that we had envisioned was, given the sim volume, what volume is acceptable at the time of treatment? But I think your point is kind of saying, should we have a no-go at the time of sim as well? And I think that that's a great idea. You know, I think if you have a patient that you're imaging at the time of sim and you see that their volume is some, you know, huge number, then you probably should take them down, maybe mitigate that and then re-sim. It adds a lot of extra time, but it could, you know, help the dose distribution down the road.
Yes, and so another question for Drew. I think it's a very nice work that you managed to automate everything in 30 minutes and completely automate that. So my question is, because conventionally for these emergent cases, we treat with just jaw fields without, and usually it's done by physicians and therapists alone on the weekends. So with your new workflow, what kind of additional clinical team do you envision that we need to brought in during the weekend for this? And also, second part of that is, can these plans now be used throughout the treatment course for the patient without being replanned?
So I imagine in the beginning, if we do start doing this clinically, a dosimetrist will be available, you know, to troubleshooting any issues. But really what I envision is that since it will all be automated, that the physician can, you know, run the treatment planning script, and then, you know, maybe the therapist can run the contouring script, but really they should be able to do it without a dosimetrist or a treatment planner, or that's my hope or envision. And then, the second question, I think, at least based on all the testing I've done, all the results I've seen, the accuracy of our plans calculated on these cone beams is quite good. Even if you do look at point doses on that table, at least I showed the max point dose difference was only 5%. And again, like I said, mean doses are agree quite a bit better than that. So in my opinion, I think we could use this treatment, you know, the whole length of the patient's treatment.
Thank you. So I think that
Yeah, just
there's
a question
okay.
for Megan and for Drew too. So my question is, now we have enough experience now, at least for head and neck cancer patients, with you know, using cone beam CT to do a quick deformable registration and look at the dose distribution. So my question is, at what point we will feel comfortable to start doing that adaptive radiation therapy just based on cone beam CT scan?
Yeah, so I think the question is basically, you know, when have we done enough analysis to know that it will benefit our patients to adapt their treatments? So I think there's a really good trial that's happening in Europe right now called ARTFORCE that's probably going to give us some indication of how beneficial this is for head and neck patients. I think there's some questions that have to be answered in terms of the radiobiology, because a lot of the data that we have from our clinical trials are not using actual delivered dose, they're just using planned dose. And so that's a really open question that the field has to answer. For our patients, you know, I think when you look at that one patient whose parotid dose was 90% higher by the end of treatment, if you've been doing weekly analysis and you start to see differences that high where you're getting uncomfortable and you wouldn't have wanted to, you know, accept a plan like that, that's the point where we probably need to be making changes just to be conservative. But in the long run, in terms of, you know, adapting on a more regular schedule, I think we need that clinical trial data in order to really know how beneficial it will be.
But my question is more also for the planning using just cone beam CT scan, because we're doing that, but we're not really changing the treatment.
Right. So yeah, there's two options that you have to adapt. So you can either take that adapted cone beam CT and replan directly on it, or you can re-sim the patient. And so I think what we would have to do is more of a quantitative analysis of those adapted CTs to see if their quality is high enough for us to use them for planning. For some of our patients, that's definitely the case. So we could replan on those images. But for some of them, for instance, if you have a big shoulder difference between the time at the sim or at the treatment, you're going to have these jagged edges that you have to account for at the edge of where the cone beam ends and where the sim CT is appended. And so if you have effects like that, you might want to consider re-simming that patient to get a higher quality image to replan on.
Thank you. So final question is from the audience offline. So this is for Drew, and about how the contouring part it's fully automated in Eclipse.
So yeah, the contouring is fully automated, and it's using a separate workspace in Eclipse called Smart Segmentation, and what it is auto contouring basically. It'll adapt contours from a similar patient in our library to your new CT. So it's not perfect, but for these emergent cases, I think it's good enough. And I think the most important part when doing this is the target volume. So we'll have a break in the script that allows the physician to quickly edit that target volume if they want to. But otherwise, it's all automated.
Okay, thank you all. So another round of applause for all the speakers and also participants today. Thank you very much for sticking with us through this long day, and hope the sessions are informative for everyone, both virtually and here on site. Just a reminder that tomorrow the session will start again.